So these are the things I'm going to ask. I'm going to try to answer. My first encouragement, I think you already know, and that is that we, as Kevin said today, we don't know exactly what it is to walk in your shoes, but we do want to walk with you on this journey, and you are not alone. So there are resources that this community is uniquely able to connect you with, and I hope that you sense that in a very real way, that you are not alone. I listed a few resources for you. Number one, of course, being the MSUD support group. There are a few other groups besides your physician team, which is strongly encourage a great kinship and bond with your local metabolic and pediatric team or adult care team for those of you that are adults. There's a few other groups. One is called Transplant Families. This is a 501c3 organization that is committed to transplant families of multiple different organ transplant needs: kidney, heart, intestine, and liver. And they're a resource that we've worked with in the community that potentially could be a resource for you. So I encourage you to consider reaching out for transplant families at the right moment. The other is a network that we began 9 years ago called the Starzl Network. There are resources on this network. It is a collaborative of 24 United States institutions that are committed to sharing best practices, sharing their data with urgency to solve some of the critical problems that transplant patients face. And there's some public-facing resources that are available to you. Primarily the one I list here is called the SRTR. It stands for the Scientific Transplant Recipient Registry. And that's a publicly available resource where the high-level outcomes, at least up to 1 in 3 years after transplant, are available for all the programs in the United States, and that they're updated on a regular basis. This is what the website looks like for, I'm not advancing here, so I apologize. I'm advancing on mine, but not on the screen. Let's see. Okay, I think okay. Sorry about that. That's why everyone was looking at me rather quizzically. Okay. So resources. The first one that I mentioned, at the bottom of the list, the SRTR. This is what the website looks like for the Scientific Registry of Transplant Recipients. It is a site that is mandated by the government, contracts that administer transplant in the United States, and has data on all the transplant centers in the United States. If you use this, you can search by organ type, you can search by zip code, you can search by program name, and this is a resource that tells you at a glance the high-level outcomes for each program in the United States of any organ transplant. So if you look, for example, at in Pittsburgh, you'll see something like this that gives you an overview of the outcomes for the program. It lists each of these dots represents a program that is doing the solid organ transplant that you select. So if you hover over it, you'll be able to see which program it is, and the program in particular that you've highlighted, if it's children's, would be the one in blue. So you can tell that that's the specific program. These hazard ratios are important to understand what kind of data it shows. It is an attempt to show statistically if care at a particular center is more likely to yield a desirable outcome than expected or less likely to yield a desirable outcome. And so when you look at this bar, you can see that there's a lower chance of having graft failure for patients transplanted in Pittsburgh compared to all the circles that are above that. And then the other program that has a similarly good outcome is the Children's Hospital of Los Angeles, that is to the right here. The more transplants, the higher volume, the greater that circle moves to the right. and the better the outcomes, the lower the circle moves to the bottom, away from the average. You want to be at least at the expected mean, and you don't want to be highly above the line for those outcomes. These are not perfect. Sometimes there's complexity in including patients that are waiting for multiple organs, and it's not completely representative of the case mix index that might be seen at institutions, but it's a start for you. And it's something that you would complement with asking your physician team more specifically to follow up questions. I mentioned the Starzl network. There's some resources that are geared for family members that are generated by patients and centers that are participating in the network. And this allows you to look at what the type of questions that parents, patients, older patients have deemed to be important. So this is a resource that's available on the Starzl Network resource page. There's some videos also for younger children, perhaps age 5 and above, about what life is like for a transplant that are done with animation and some tools for that age group as well. The second topic that I wanted to address is what type of transplant is my child going to get? And this is just to answer the question for those of you who are considering transplant. The types of transplant that we consider are the following. Number one is a whole liver transplant from a patient who has deceased and whose family has allowed the donation of that precious gift of life to be given. That's called a deceased donor whole liver. In children, the splitting of the liver is allowed by the way that the liver has been able to be partitioned into different lobes, all of which carry the same vascular and arterial and venous and biliary anatomy, so that split livers represent a valuable type of graft that is common in our transplant population for children. Because it is sometimes difficult to get a whole liver that from a child who has passed away, and sometimes the outcomes from that liver are not as optimal as actually doing a split graft from a young adult donor. The other similar option that uses that same technique is called living donor liver transplant, where the left lateral segment, this portion that's shown here on the right, is recovered from a living donor and able to be transplanted into a child. And it's able to grow because the liver is really the only organ that regenerates in the body and is able to grow with the child. The liver mass that is needed to provide the cure for metabolic conditions, in particular maple syrup urine disease, represents the liver mass of the body. And so 2% of our body weight is approximately what our liver weighs, and that is the amount that we transplant, whether it's a whole liver from a donor that has passed away who's an infant, or a technical variant graft. That volume is what's necessary more than whether it's a whole or partial liver. We also do a lot of living donation in Pittsburgh. We recently performed our 200th living donor. And in the United States, this is the largest volume for living donation in the United States. But it is far smaller than what is done in other parts of the world, such as Asia or the Middle East, where living donation is the only form of transplant. In the United States right now, living donation for children awaiting a liver transplant is about 15% of the entire population. Technical variant grafts are another 15% from a deceased donor, and about 60% are whole liver grafts. In centers such as ours, the majority of patients either receive a living donor graft or a technical variant split graft with excellent outcomes for both of those populations. I wanted to briefly touch base about traveling out of state and second listing. The OPTN, which stands for the Organ Procurement Transplant Network, is the government body that administers transplantation, and there are policies and rules for all that exist to support all transplant patients. These are some frequently asked questions, and so the one I want to address in particular is that in the United States, patients who are being considered for transplant have the right to list at one or more centers. It's called multiple listing, and it's something that is mandated to be shared as a possibility with any patient who's being evaluated for transplant. This is important because in MSUD care, the best care may not be the care at the center that's closest to you. And so it is a question that you need to investigate and we need to talk about further. So because it may be difficult to initiate some of those conversations when you have a local center that is willing to do your transplant, how do you initiate that conversation about perhaps traveling for a transplant or traveling out of state for a transplant? I put together just a few ways to start that conversation, and these might be some of them, and maybe families who've traveled or who've had that experience may have another suggestion. But these are some possible ways to start that conversation with your local team. You could say, I understand second listing is an option, so I'd just like you to tell me about that. If I decide to do that, and this is I'm speaking as the parent or the care provider, where would you recommend I go, and who can help me from this team, that the team I'm visiting with, to help me start this process? Because what you don't want to do is to feel like you're on your own trying to initiate this investigation of transplant, potentially at a faraway distance, alone. And really I believe that your care team really owes it to you to help start that process and support that. We certainly do that when our patients ask us the same thing. And I don't know if there's any questions about second listing before I move on. Yes.
On that last point, the other folks you can ask locally are your metabolic physicians.
Yes.
And they have no stake in where you have your transplant other than best care. So that's a good option as well.
Excellent. Thank you. Any other questions on that? Perfect. We're going to talk a little bit more in the second session. Yes, Stacey? Yes, that's a great question. So the question is, what needs to be done at another center? And the policies do vary by transplant center. There are unique situations where we are partnering with other institutions at other transplant programs. For example, in Pittsburgh, we also partner with Virginia and Florida and Orlando. And that may allow the facilitation of the transfer of information in those cases. For the most part, the centers will tell you that a physical visit to do an in-person evaluation is important, and there are some requirements medically at each institution. For example, blood work to be done, and another test that have to be done at that listing institution. So an in-person visit will be required in all cases, but the length and the details of that do vary by program. We're going to talk more in the next session about the outcomes, but what I think we have tried to share so far in the meeting, and what I hope you've heard, is that transplant at an expert center does allow for an unrestricted diet in the post-transplant phase that we have shown is persistent over at least 10 years of data. We believe it provides lifelong metabolic control on an unrestricted diet. And episodes of hyperleucinosis post-liver transplant are very rare. In our situation, in our series of it's occurred in 1 out of 140 cases, and there's been published cases that seem to indicate it may be more likely with a living-related transplant, so we don't recommend a living-related transplant from a carrier transplant right now in the United States and in our program. But it can occur under conditions of catabolic stress like a gastroenteritis or flu-type syndrome. It's occurred after a tick infection and other episodes in the literature, and there have been case reports of this occurring. There have been no cases that I'm aware of any persistent neurologic condition post episode. These have been transient and corrected with routine IV fluid administration and medical care. Someone has asked me about retransplantation, and it's important to know that the liver, leveraging its very tolerogenic state and its really the way that the body accepts the liver, we expect that a patient who receives a liver transplant will keep that liver for their lifetime. Retransplantation should be very rare. We have retransplanted one patient out of our current population, and we would expect that should be a very rare phenomenon. For general patients undergoing transplant, the retransplant rate is approximately 10% over their lifetime, and this occurs due to chronic rejection or biliary changes or other rare events, but it has been infrequent in the MSUD population at our 20-year experience. I'm going to talk about other ideal outcome metrics in the next session, but this is the concept of, in addition to a liver that is functioning and a patient is doing well, that more granular detail about what that patient's life is like. How many medications are they taking? Do they have complications related to their medicine? Are they functioning well? Are there subtle signs of any liver injury or graft injury that requires any procedures? These are part of what we consider a composite ideal outcome, and we'll talk a little bit more about that. I mention it here just to emphasize that our goal as your transplant team, your medical and surgical team, is to really not just look at the liver health, but it's to look at the overall health of the child in every way, developmentally, from a medical management point of view, and from a lifelong care plan for that child. I wanted to share just 5 additional things, and then Stacey's going to come up and kind of share some of the insights that she wanted to share about some practical steps in being evaluated. These are just 5 additional things that I've listed here. One is that your advocacy for your loved one is very, very critical. So it's going to be important that during this phase, during the transplant phase, and then after transplant, that advocacy will need to continue. Not all transplant centers are equal, and so I really encourage you to ask detailed questions at the transplant center that you go to about their transplant experience, their practices about managing immunosuppression, and the details of how they go about their care and what to expect. It is important to note that transplant is a lifelong commitment, and although the care may improve dramatically for patients who are on a limited number of transplant medications compared to their MSUD care, that they are being committed to lifelong care, monitoring of their liver, surveillance with their transplant team, and that this is easier in many ways than MSUD management, but it does require a commitment. We have seen challenges at times with patients once they receive adult care and are being cared for in an adult institution, that they feel that they may not need to have that same level of vigilance as they did when they were undergoing regular monitoring with the pediatric care. And this is an area that we want to a strategy we want to discourage. It is really important that you have continued follow-up with that care team throughout your life. We do expect that lifelong immunosuppression would be the norm. It is going to be a low level, we believe, and liver recipients have the lowest need of immunosuppression of any solid organ transplant recipient, much less than heart, kidney, intestine, and lung recipients. So one medicine is the typical medicine that is anticipated to be needed. So, and we can ask some of our patients in the room what their experience is now many years after transplant. But that single medicine is likely to be expected, and we can't predict which patients can be on very low levels or if they can come off medicine at this time. And we want to emphasize again that lifelong liver health monitoring and health monitoring in general, especially as an adult, for conditions that may be increased on immunosuppression is very, very critical. This is our team, and we want to welcome you to ask any questions while Stacey's coming up to give her presentation. I'm happy to take any questions on transplant. Thank you.